everyone, and welcome to today's webinar from the International Initiative for Impact Evaluation, 3IE, and the Society for Implementation Science in Nutrition, CISN. My name is Isabelle Michaud-Letourneau, and I'm the Senior Technical Lead working with CISN on several projects, including the Implementation Science Initiative, which will be the focus of today's webinar. Just a little bit of housekeeping before we get started. If you have any questions during the presentation, please type them using the Q&A function and not the chat function in the Zoom platform. We will not be monitoring the chat for this purpose. You may send in your questions on the Q&A function at any time during the presentation. We will have a Q&A session at the end of the presentation, and I will pose as many of your questions as possible. If you experience any technical issues, please also type your questions in the question box, and our staff will help address those issues. We're also active on Twitter and encourage you to chat and engage with us through our Twitter handles and hashtags. You can see them on your screen. Finally, a recording of the webinar will be made available after the session. Before I introduce our first speaker, I'd like to set the stage by sharing with you some background about the Implementation Science Initiative in Kenya and Uganda. It's an initiative from CISN that is carried out with 3IE thanks to a generous support from the Bill and Melinda Gates Foundation. We're very grateful for this support, and today you will hear from our partner in Kenya. So the plan of the presentation is this one, a short introduction that I will make shortly. Then we will talk about the focus ethnographic study for the first part, and we will move slowly into the programmatic context and the implementation research together. For some of you, you may have heard in April, we have done last year a webinar on the Implementation Science Initiative, and I will not touch deeply on those components, but there are 6 components that are taking place in the 2 countries. And those are helpful to try operationalize an implementation science in those countries with the country team to address some issues on iron and folic acids supplementation programs in those countries. So first, in each country, there is a national core team that has been created for this purpose and that carry out a bottleneck assessment and inventory that help to address bottlenecks in an ongoing manner. There is also the component of knowledge brokering that is important in order to make sure that the most available evidence is used, but also the tacit knowledge of people there. And today we will be discussing the implementation research component, which is the 4th one, for the Kenya team, because they are applying the focused ethnographic study approach for their implementation research. What is important in this initiative is we also try to use existing knowledge before producing additional one. And finally, the 2 other components are the Implementation Science Network and the documentation of experiences that are taking place in both countries. So now I'm moving into our first speaker, Dr. Gretel Pelto. Dr. Pelto is a graduate professor at Cornell University, Division of Nutritional Sciences. A medical anthropologist by training, her teaching and research has focused on maternal and child nutrition, community nutrition, and program planning and policy. During the 90s, she directed behavioral research in the Division of Child Health at the World Health Organization, Geneva, Switzerland. Her research experience includes work parts of Latin America, Asia, and Africa. The primary substantive focus of her work is infant and young child feeding and the design of nutrition intervention to address nutrition problems in vulnerable populations. Her theoretical and policy focus is on the interface between programs and families and communities. She is a recipient of a number of awards, including an honorary doctorate in nutrition and food science from the University of Helsinki and the Malinowski Award from the Society for Applied Anthropology. This award is given to an outstanding social scientist in recognition of effort to understand and serve the needs of the world's societies, and who has actively pursued the goal of solving human problems using the concept and tools of social science. It is an immense honor to welcome her on this webinar. So Dr. Toto, the floor is yours.
Hello, everybody. I assume that I'm getting through. And thank you very much, Isabel, for that gracious introduction. I plan now in the next few minutes just to take everybody briefly, very briefly, through some background about the concept of focused ethnographic studies. A focused ethnographic study is an FES tool to answer questions that are required by agencies, by policymakers, by program planners, or by project implementation.
Excuse me?
Yes?
Excuse me, Gretel. Just make sure that you share your screen. I don't think we can see it now.
Oh, uh-oh. All right, just a moment. We'll go back to the beginning.
At the bottom of your...
Yeah, the problem is I've already hit the slides. Oh dear.
Just escape, just touch on escape.
Got it. Okay, now, I'm very sorry for this delay. Share screen.
Yes.
Well, it seems as though I've lost the capacity to share the screen.
I think 3IE may help. They have the possibility to try share your screen, but if you can see at the bottom, there is the share screen.
You know, I think that to save time, the best thing to do is for me just to talk through the slides, if you don't mind.
That's okay.
I think that's what we should do. So let me continue with just an oral presentation without the slides. The general purposes, so I just briefly, the general purposes of an FES are to inform and support decisions about future actions with respect to social and public-private partnerships, and to modify programs to make them more effective. The goal of an FES is to obtain information on conditions and behaviors in a population that are important for various decision-making activities, including planning interventions that are appropriate for local conditions, identifying potential bottlenecks that are likely to affect the success of an intervention, designing and developing communication strategies and content, especially for behavior change communication, and deciding whether a proposed intervention is likely to be feasible or effective in a given environment. For public health interventions, an FES is usually one of several components. Often the first step is in the process of developing the implementation plan is a review of published papers. And this review permits planners to summarize what is currently known about the problem, the knowledge that is gained, the epidemiology, the types of interventions that have been used previously, as well as evaluations of effectiveness of implemented programs. So, back to focused ethnography. First, it's a mixed method tool. It typically employs both in-depth interviews and other data collection methods that lend themselves more readily to statistical procedures. Ethnography is usually collected in small samples, and like other types of implementation research, the ethnographic or qualitative component always faces severe resource constraints. And for that reason, in-depth interviews or focus groups followed by text analysis may be the only feasible approach. However, the design of the FES usually includes tools and techniques that produce readily quantified data as well as descriptive data. An FES is typically, well, an FES is always designed to keep in mind it has three main features. They're designed to address a specific set of programmatically important predefined questions. They are grounded in a strong theoretical framework, and they attempt to preserve the strengths of data collection and analysis that are typical of ethnographic work. So, for example, in the FES that we created for infant and young child feeding, the protocols consist of in-depth, open-ended interviews with guided discussions, formal cognitive mapping techniques to describe cultural domains, socio-demographic data, 24-hour recall for the infants and young child in the household, and a 7-day food record, as well as open-ended questions on food preparation, storage, feeding behavior, and caregiver perceptions about the effects of food availability, food insecurity, and seasonality. That's an example of what was included in the FES on infant and young child feeding. Typically, data collection is conducted in two phases. The first phase consists of interviews with key informants, and the second phase consists of in-depth interviews with a purposive sample. For the Kenya project, the content of the modules must be IFA-specific issues. So the design and execution of the IFA-specific protocols is what the Kenya team is doing now. And with that short introduction, I think it's time to turn things over to the Kenya team. Thank you.
Thank you so much, Dr. Pialto. To all, we're sorry about the logistic or technical problem, but at the same time, it gives also a short introduction to the focus ethnographic study. Now we'll see an application by the team in Kenya, and shortly after, you'll have the chance to speak and ask as many questions as you'd like to our speakers. So now it's my pleasure to introduce our next speakers, two-person. We have Brian Njoroge and Dr. Zipporah Bukanya from the Kenya team. I will start with Brian, a short bio. He's a nutrition professional with significant technical experience in program design, implementation, monitoring, and cost management. He has been a leader in building and effectively managing teams that execute and deliver social impact to their communities. He is very result-oriented manager with methodological approach to problem solving and implementation of feasible solutions. He's a passionate advocate for engaging communities in finding sustainable and lasting solutions. Currently, he is the co-investigator for the iron folic acid implementation research study in Busia in Kitri. I'm also introducing Dr. Zipporah Bukanya, who is the Deputy Director from KEMRI, heading the Center for Public Health Research. She has strong academic and professional training in applied human nutrition with over 20 years of work experience in both clinical application and research. Her doctoral studies training is in applied nutrition. She has been involved in a wide range of nutrition research activities, focusing majorly on generating evidence to support policy formulation and development of government guidelines for the implementation of nutrition program. Dr. Zipporah served as various national technical committees in Kenya, as well as mentors nutrition graduate students from various national and international institutions. So I'm happy to hand over to the team. So thank you very much. Go ahead, Brian.
Good morning and good evening to our attendees. So I have a few slides here on what we are doing here in Kenya. So Dr. Zipporah will talk about the ethnographic study design, and I'll just introduce what we are doing. Very quickly, the ethnographic study will be implemented. The ethnographic study will be implemented in Busia and Kitui in Kenya. We'll do it using the Baby Friendly Community Initiative platform. And basically, the BFCI, as we refer to it, is an initiative that supports breastfeeding, optimal complementary feeding, as well as maternal nutrition. The focus here will actually be more on maternal nutrition because we'll be dealing with iron folic acid supplementation. BFCI is implemented through community units and that are linked to primary healthcare facilities, working through community mother support groups. Currently in Busia, we cover 19 community units with about 1,477 children under 1. In Kitui, again, we're in 4 sub-counties with 17 community units covering about 1,521 children under 1. So each of these children have a mother, so that population also is synonymous to their mothers. So for the focused ethnographic study, we are looking at the social-cultural model, and I think Gretel has actually talked briefly about this. And our focus will really be looking at pregnancy, as you can see on the slide, and looking at the social environment, the physical environment, the organization, the culture, and the technology, and how all that affects the culture and the perceptions of this mother. I'll also talk about, now for these social-cultural elements that affect pregnancy, the key ones are within the social organization, technology, as well as culture and physical and social environments. The economic condition of households, for example, within the social organization is an example of, something that would affect incomes, expenditures, and this affects how and when these mothers disclose their pregnancy, as well as when they attend their first ANC visits. In terms of culture, another one is culture, is really the knowledge and beliefs and the perceptions within these two communities. And I'm going to highlight these two as we go along. So the objective of a focused ethnographic study, which also happens to be the first objective of the approved protocol, is really to investigate the barriers of early initiation of the focused antenatal care package services, including the late disclosure of pregnancy and subsequent focused antenatal care visits. This objective was developed through a process of bottleneck assessment, whereby we had teams from various counties, and we identified vulnerable populations as well as issues around why mothers do not consume iron folic acid supplements. Again, we will conduct the ethnographic study in just these two counties. During the bottleneck assessment, this is a snapshot of some of that work. The teams were able to identify hard to reach and vulnerable populations that are in these two counties. And the discussion was that these two populations are the ones which contribute to a majority of the mothers who actually do not consume IFAS, as well as those who do not disclose their pregnancy. Now, the key thing to note is what I discussed earlier: culture, the social organization, as well as the different demographies of this. The similarities is that the adolescent populations was prevalent within the two counties. So I'm going to give a context of the two counties. So this is Busia. It's on the western side of Kenya within the Lake Basin. Predominantly, it's inhabited by the Luya community, those who are familiar with the Luya and the Tesong. Majority of them are Christians, and fishing is the main economic activity. They have 7 administrative units, sub-counties. For those who are in other regions of the world, they're the same as districts. And from the census we conducted last year, it has a population of about 886,000, and the average household size is about 4.5. In terms of size, as you can see, it's not that big, but it's a high potential. Within the agroecological zone, it's considered to be high potential, receives significant amount of rainfall, and in some areas, it's prone for flooding. So within the groups where we work, I just wanted to highlight, give some background on the distribution of the age of the mothers, like I had mentioned. If you look at this, you find that you can see that we have about 15% of our mothers who happen to be adolescent. The graph actually shows that the age is skewed to the left, and therefore we have very young mothers who are in our groups. When you look at the parity, that's how many children they have. We can already see that from this group of mothers, that at least 29% have had at least one child. And within the adolescent group of 10 to 19, we find that at least 10% of them have had at least 2 children. So a majority of who we are dealing with in this county happens to be within the, more or less, within the adolescent group. Kitui County, it's more in the eastern part, so very different from Busia. It's inhabited by the Akamba community. The population is much larger, about 1.13 million, and the average household size very similar to Busia. In terms of size, as you can see, it's 30,496 square kilometers, extremely big and vast county, and it's considered to be semi-arid. It has 8 administrative units. The ones in bold are where we will be doing most of the work. So again, when you look at the age distribution within the mothers and within these baby-friendly community groups, we begin to see the pattern is very similar to Busia. We have more mothers skewed to the left, and we see that at least 44% of the mothers had one child before they turned 25. When we look at the parity, the story is very similar to Busia also for the adolescent mothers. And we see that here the more mothers have actually had at least more than one child by the time they hit age of 25. Now the thing to note about the socio-cultural context of these two counties is that they have strong cultural beliefs and practices. In Busia, because they are fisher folk, there's a cross-border community, and in one of the counties, we see that there's a number of adolescent and teenage pregnancies. In Kitui, we have an indigenous sect where we work. We also do have quite a number of adolescents with high teenage pregnancies, and we also have a pastoralist communities. So these affect those dimensions, and that's why we are doing the ethnographic study to try and understand what actually happens when they turn pregnant. I'm handing over to Dr. Zipporah to take us through the next slides. Thank you.
Greetings, everyone. This is Dr. Pukania. So I'll pick it up from where Brian has left. And I'll just, because of time, I really won't go back into a lot of details, but just give a snapshot of what or how we intend to undertake the first study. One of the key things that we must do at the initial stage is to do household mapping. Now, the privilege we have is that programs have been going on in these two counties, which are related to the activities that we want to do. So we already have some structures in place that we can fall back to. But as you can see from that slide, we have quite a number of villages that we intend to target. But most important is that within the setup of the counties, we have the community units which already exist. And so we'll try and map a total of 291 community health volunteers who cover a total number of units of about 30, and mainly those who are involved in implementing BFCI. And those are the ones that we most likely would want to use in implementing our activities. If you note, we also have, the two counties have quite a number of villages, with some sub-counties having as few as 8 villages and others as high as 51 villages. So it's quite vast in terms of the numbers. So we have about 6 instruments that we intend to use. So we have the Pregnant Women Key Informant Interview Guides. Then we have the Pregnant Women Respondents. So we have 2 methodologies that we'll use. I think if you remember what Gretel said, that usually you could use key informants, you could use in-depth interviews with the respondents and many others. But in this case, we'll focus on the key informant method and the interview with the respondents. Then we also have SEM for the pregnant, non-pregnant women, for key informants, and non-pregnant women who will also undergo in-depth interviews. And then the health workers for key informant interviews, and influencers of pregnant women will also be interviewed as key informants. So what we have also tried to do is to form an advisory group for the implementation science within our network. And the names that we see on our screen are basically the members of this advisory group. Within the same members, we also have the study investigators as well. So we have the advisors, including Gretel and Isabel, who is also part of the investigators. And then of course, the rest of the team is investigators. As we can see, representing different institutions, we have the Kenya Medical Research Institute, FHI Partners, Ministry of Health, Nutrition International, and nutrition specialists from FHI. Now, how have we sampled? In these 2 counties, we are going to sample first the sub-counties. We'll first sample 3 sub-counties which are listed there in Busia and 4 sub-counties in Kitui. Then the next administrative structure will be the wards, and then finally we select the villages. Now within the villages, we've itemized how many villages per ward that we'll be able to reach within the program. So of course there'll be more villages in Kitui compared to Busia, because Kitui also has a higher population. It's also much more vast. How is the study design? So we first start with the key informant interviews with the critical interviewees that we think will be able to give us critical information that can then help us determine what areas of investigation or questions we'll need to ask the respondents. So our key informants are basically spread across the different wards within the 2 sub-counties, or the 2 counties rather, and we're only doing a total of about 24 of them. Then arising from that, we'll develop our tools, and then we'll undertake the interviews with now the respondents, who are also grouped in 4 categories: the pregnant women, non-pregnant, healthcare workers, and influencers. The distribution of the respondent is also dependent on the population group, because our interest is a pregnant woman, so we'll have more interviews with the pregnant women, but the other groups will simply have a reasonable sample size that can give us reasonable information for analysis. Now, the purpose of this really is we want to understand, like we mentioned earlier, is that culturally there are different behaviors that are affecting issues around attendance to health facilities to seek for care, or for purpose of trying to understand why mothers or women do not disclose their pregnancy early, and probably if that is one of the reasons that makes them report late for ANC services. And of course, being a qualitative study, all the respondents are basically going to be purposefully sampled, and so with the key informants. So we'll sort of have some guide on how to select our key informants to give us critical information, basically looking at people who are knowledgeable about each community, who have an understanding of the behaviors and cultural behaviors of the population in their respective sub-counties or even the entire county. So we'll have an array of informants based on that. We have a team that is basically preparing to undertake these interviews based on their professional experience, and they're also co-investigators on the study. But specifically, each interviewer has a specific area of interest and focus, so that we have Dr. Otambo Echoka and Lydia Nyanjeka from Kemri, who will interview the influencers, the health workers, and pregnant women respectively, while Dr. Mwangi will focus on the non-pregnant women throughout the interview process. How will we manage our data? All the interview teams will include translators and transcribers. And we are looking at this because we also anticipate that within the different communities, there's a possibility that we will encounter respondents who probably will not speak English or Kiswahili. And therefore, if we undertake the interviews in the local language, then we will need to have that transcribed and then translated. And because of, for convenience of the teams, we'll try to have this done concurrently. And each interviewer will actually focus on the transcriptions of the interviews that they undertook, so they can confirm that the interviews or the recordings that they had done are actually correct. And immediately we have that done, then the rest of the technical team will now review all the sets and pick out the themes that are critical for follow-up or for the next steps of the study. Of course, themes will be guided by the respondents' focus. And so at this point, we cannot determine how many themes we will have, but we'll try to sort of coordinate them to give us critical outputs out of that. So it's basically a two-stage process that supports that whole process. We have stakeholder engagement. So within our advisory group, we are also engaging with the country's Ministry of Health, Department of Family Health, and the Division of Nutrition and Dietetics, and we also have the Division of Child Health. So they are part of our advisory sort of stakeholder engagement, where we have briefings and updating on the processes of the activities and where we intend to do this work, but also to have them as an accountability group so that they also know what is going on, and should there be any reason for findings that would inform policy, then they sort of have an understanding of that will be done, how that can be done. Then of course we have a number of course, like now the webinar here is one of our outputs. We also intend to have this in terms of publications, in terms of posters, public presentation in conferences, as well as having the findings disseminated within the counties that will do the work, as well as at national level. So having said that, I think what is critical is just to know that objective number one, which we are focusing on right now, is part of other activities within the bigger project. But this particular activity on FACE is really what we want to start with before we can even determine what the other objectives, how the other objectives will actually be implemented. Thank you very much.
Over to you, Isabel.
Thank you so much, Brian and Zipporah, for a good presentation of the application. I know there is a lot of things to cover in a very short period of time, so I hope the participants have a small overview. Now we have time for questions, which is really a time that can be rich in terms of you asking questions that you would like to pose to our speakers. I'd like to ask the first one because back to November, in preparation of the focused ethnographic study, that is something that is new to many of us. We had the chance to interact a lot with Dr. Pilto, and she was very generous in terms of sharing insight. And one thing that we discuss a lot, and I think it can be a criticism or questions about focused ethnographic study, is when you have only a small sample, sometimes that we like to say, how can we talk a little bit about generalizability after? And I wonder, Gretel, if you can just share your thought about this, because sometimes we want big sample, but at the same time, that's not always appropriate, and especially for focused ethnographic study.
Fine, I'm happy to jump in and try to answer that extremely important and difficult question. The issue is really one of representativeness. How can you claim to be representative when you have such small samples? And why do we worry about representation? Because we're designing programs for large populations. So the problem can be, I think, articulated as you can have larger samples if you predefine the questions, and you can have even larger samples if you predefine the categories of answers. But how to do that? Who are the people who are the right people to do it? So we know, for example, now that women are going late to services. The question is why? Is it enough just to tell them they have to go earlier? Of course not. We have to understand why. And the problem of understanding is that that's very expensive in terms of time and also resources to interview people. So we're stuck in a serious bind between getting meaningful data and predetermining what kind of data we get. This is the critical issue, not just for focused ethnography, it's the issue that all qualitative research faces. the idea of the FES is that you try to streamline the process sufficiently that you can, it doesn't solve the problem of representativeness, but it's one of the things that I've been working on very recently is the matter of looking at intra-group variability within these very small samples and seeing whether there's any variability there that actually has implications for how you reach people and talk to people. We've recently done some work that suggests that the variability in terms of generalizing how people behave is that cultural variability on that score is relatively low. But what's not low is how individual people think about it, for the implications of that for how you reach them. Let me give you an example from a recent focused ethnographic study on how women choose what they are going to give their infants and young children. Some women say, I rate foods, or I understand the value of foods in terms of how well I like it, how well it tastes to me. And other women say, how well children use it, how well children eat it, how well children seem to like it. Are both of those answers right? Of course they are, because they represent the position of people. When you design communication strategies to reach those, you need both kinds of concepts represented. So one can look at variability even within very small samples and pick up on issues that probably need to be addressed or do need to be addressed in the behavior change communication strategy. And similarly, in relation to actually interactions with social health services. So that's rather a long-winded answer, but I hope it addresses some of these issues.
It does. Thank you so much, Gretel. I think that's important for all qualitative research also, as you mentioned. I see a few questions that are related to our use of acronyms, so I apologize. In nutrition, we use a lot. So TWG is the technical working group. We often use that one. NHP, it's the Nutrition and Health Program. That is the one implemented by Brian and his team from FHI 360 in Kenya, and partner in Kenya. And so this whole initiative is with this implementing agency. They are the partner there. Now more to another questions. I have one for Brian, that is how folic acid and iron were addressed through in-depth interviews. And so I think maybe here, what I'd like you to touch on, Brian, is the interventions or the package that will take place, because as Zipporah mentioned, this is part of a broader study. It's only done to make sure that they understand well the context and that the intervention that will be implemented is addressing some of the challenges and tailored to some new insights. So over to you, Brian, if you can touch on this.
Thank you, Isabel. So the study is implemented in a number of phases. The first phase, has been discussed, is an ethnographic study, and yes, there are some interviews which will be conducted for the mothers. Now, the understanding for this question is that how we arrived at this decision on folic acid and why we are doing what we are doing is because we are trying to understand the problem on late disclosure of pregnancy as well as late initiation of a focused antenatal care package. Now, iron folic acid supplementation is administered to pregnant women as part of focused antenatal care. And usually when you present yourself to a clinic, you're supposed to receive this as they do your antenatal care profile, so that they are able to now monitor the number of visits for until you deliver. So what has happened in this country is that we've had a problem whereby mothers come to the clinic in the 3rd trimester. And at that point, it's even if we administer iron folic acid supplementation, it will help the mother, but the idea is that if we got them earlier, we would have intervened and probably been much more successful with the supplementation, as well as maybe influence the pregnancy outcome. So the ethnographic study really enables us to understand that problem. Why don't they come early? Why don't they disclose? What are the issues around iron folic acid supplementation? So I hope maybe that sheds light. Now the second part of the study, which is really implementing what we call an enhanced package, is that really we will focus on working at community level. That is using the baby-friendly community initiative, whereby you have mother support groups. We'll use these mother support groups to help us identify mothers who are pregnant, and this is very early within the first, like within the 1st trimester, and try and bring them on board. Now, these groups have shown that they provide what you call a safe environment for these mothers to discuss openly issues around pregnancy. So because the groups exist, if one of the ambassadors is able to reach out to a certain neighborhood where they are and find a mother and bring them on board, maybe it might be easier. So the enhanced package will entail household mapping to identify pregnant mothers. It will be done much more frequently. Secondly, we'll look at conducting outreach activities, that is going to the communities where we have a group of pregnant women with a team of professionals from the Link Primary Healthcare facilities, and providing them with initiating the focused antenatal care package. And hopefully that will be done within the 1st trimester. So we'll use this network, the infrastructure at community level, to be able also to monitor and ensure that these mothers attend their ANC visits. Of course, this will be done through community health volunteers who will have defined messages, as well as a very clear activity plan on how to follow up these mothers, as well as what to discuss and when. So those are the 2 segments of the study. The third involves really looking at we'll be looking at the effectiveness of these interventions. I think we can discuss that in future forums.
Thank you very much, Brian. Yeah, sorry, were you finished?
I said I just hope I've answered the question.
I think you did well. Thank you very much, Brian. So I'm asking 2 others at the same time for Zipporah, because I think they are related. One is about the targets and the identification. If you can talk, Zipporah, about how were the influencers identify, and another question is, how do you identify target vulnerable group populations for this study?
Thank you for that. So I see the question about how influencers are identified. They're purposively selected. So we need to have some groundwork within the counties and identify people who have knowledge and who have rather identified people who are known to influence the decisions that pregnant women make. So I'll give an example. For example, in most communities in Africa, you'll find that the husband is a very big influencer. But then we will do snowballing, that once you know that this particular individual is an influencer, or this population group are influencers, then we snowball to find out who are the other possible influencers, and we reach out to them for interview. So it's purely purposively selected. The other question was, how do you identify target vulnerable populations? So in our case, our really vulnerable population is the pregnant woman. That is our major focus of interest. And going by the 2 counties that programs have been going on, there's already a lot of information about the pregnant women. That's why we will do mapping to identify exactly which households will get the pregnant women of interest. So for this particular case, it's very clear because with the established system of household mapping, that will be our best way of picking our target vulnerable population, which is a pregnant woman, because that's our major focus. I see another question: who are pregnant women respondents and pregnant women key informants? Okay, so the key informants are supposed to be a little bit more knowledgeable and sort of give guide in terms of the areas of interest of focus when we eventually interview the respondents. So they sort of give us a head start of the issues we are interested in and point out areas that we may have left out, that when then we meet the pregnant woman respondent, then they'll be able to give us further details. So a key informant is much, much more knowledgeable. A respondent is basically giving us information of the areas of interest that we have. Who are non-pregnant, multigravida, and who are influencers? I think influencers we've answered.
Yes, that's okay. So thank you very much, Zipporah. I will just quickly mention, because one question is about knowing if it's an ongoing study, and I apologize because sometimes we may be talking about the implementation science initiative that is much broader, that is also touch on the 6 component I mentioned. This study, the focus ethnographic study, is only at the beginning. So the planning is well underway, but the data collection will take place soon. And so just to answer that question, one question was about the pregnant woman respondent and pregnant woman key informant. And Gretel, I think I'd like to ask you this one, because I think the use of the term respondent and key informant, we use it very often in other contexts, but I think the one for focus ethnographic study is particular. You've touched on this, but I think if you can just say a few words in terms of the difference between those two, and if you always have those two type of interviewees, and I should say what I really learned about the focus ethnographic study, the interviews are really importantly done as a conversational mode. So it's really never like, we don't call it an interview guide. If you notice, Gretel call it a protocol. So, but it's the equivalent of having some questions, but really done in a conversation mode. So Gretel, I'd like to hear from you what you think of those points. We cannot hear you. You are muted.
Sorry.
Thank you.
Okay, I'll give you a little bit of background, because I think the idea of a 2-stage formative research of this type is something that we developed with the FES methodology. And very often what happens, first of all, I have to say that the major problem that all implementation research faces is resource constraints. And these are very often not only economic constraints, but they are also time constraints. And so one of the ways in which typically the issue of of dealing with scarce resources has been that you do one round of interviews with, in effect, key informants, in-depth interviews. And we have found over the years that by breaking it up into 2 phases, we actually can be more, if you will, focused on honing in on problems or issues or important information that emerges. So we start with key informants and look at what are the major things that the key informants are telling us. And then we do a second round with another sample to see what else emerges, or what are the details, that sometimes the devil's in the details. And so how can we learn more about what we need to know in terms of identifying barriers and facilitators by doing it in 2 stages. That's the primary motivation for this 2-stage approach.
Thank you so much, Gretel. So in the interest of time, I'm going to ask one more questions for Zipporah, because one is about, will you be exploring any questions around acceptability of other maternal nutrition supplements, such as a complete multiple micronutrient supplement, or like the multivitamin, rather than just IFA? And I know, Zipporah, you're closely working with the Ministry of Health, and I know there is some discussion. There is also the weekly also intermittent IFA for adolescent girls. I wonder if you can talk a little bit about the broader context and some ideas that are intervention that are discussed in Kenya.
Thanks, Isabel. So yeah, being a study, I know our focus of, our interest is IFAs. But generally, while we are collecting data, we'll also explore what else are people consuming in terms of micronutrient intake and many other things that they might be taking just to boost their micronutrient status. So yes, we will collect more information, and probably that will also give us answers to some of the questions we might be having regarding access to IFAs and how people perceive consumption of IFAs versus other sources of micronutrients. So yeah, we will. Thanks, Isabel.
Thank you. And so there is another question. So for people who would like to do this kind of study, an interesting question to ask is, how much time do you need? And so the question is, how much time will the entire focus ethnographic study take? If we include data analysis and report writing, how will this time be included in the program planning, considering the information is often urgently needed? So maybe, Brian, you can touch a little bit on this, because you've been very much involved with the planning. So what is the timeline that you're planning for focus ethnographic study? And maybe, Gretel, since you've done so many of those studies, you can talk a little bit maybe of the range of time, how long it can take to do this, maybe in a shorter term, in the interest of having the insight generated as early as possible. So first of you, Brian.
Thank you, Isabel. I think pragmatically speaking, we are looking at 3 to 4 months to complete everything, whereby we look at at least 1 month of data collection, and we have, the other 2 months will really be to sit through and see if the data develop the themes, because when you look at the numbers we are planning to target, it's quite a significant workload. So it's about 3 to 4 months, and this also presumes that within the first month, we have the data collection instruments with the advisory group completed, and everybody is happy, and we move to data collection. So the way we have planned this is that the data collection looks at a 1 month process, and then based on that, we go and sit down and look at the themes. So I hope that provides some guidance for those who want to do this.
Thank you, Brian. And you will be able also to find a lot of studies that have been done. Not that so many, but there are studies out there that can also provide you some great resources. Gretel, do you want to add something about the length? Because I think like the qualitative data analysis can take so much time, and the Kenya team was very ambitious with a lot of a large number, but at the same time we had to cut in the interest of time and resources, as you mentioned. So can you talk a little bit about the length that it took you to do the studies?
Yes, I'm not muted, right? Okay.
We can hear you.
I'm happy to answer that, because the answer lies, I think, in other areas that those of us working in implementation science frequently don't want to face. And that is that the time frame and the resources are essentially political in nature. Who says that it has to be implemented and moving forward this rapidly? Who is actually, if you'll pardon the expression, calling the shots in terms of the expectations. That's on the one hand. And the other hand, there is what's the downside of being wrong? What's the downside of not doing the work well enough to actually target the interventions? And I don't mean target in terms of who you target, but design the intervention so that it meets the needs of the people for whom it is intended to help. Well, when we look at evaluation research, evaluations of programs, is the glass half full or half empty? Very often, it's a very poor half full, and yet millions of dollars have been spent. So taking a little more time at the beginning and doing it, if not right, at least better, focusing it more on the people who need those programs and where they're coming from, in the larger scheme of things, in my view, will actually be far more cost effective and actually more politically successful. So it's a question really of educating policymakers and bringing them on board and making this a much larger collaborative effort.
Thank you very much, Gretel. I have a last question here that I think would be also interesting to hear. For you, Brian, what do you think can be the barriers of ANC attendance? So this person is understanding that you're mostly at the beginning, but you already have some ideas about those barriers to ANC attendance. And I would extend to also barriers that you have as assumptions for also the consumptions of iron folic acid supplementation, if I can ask you that.
Thank you for the question. So we had this discussion with the different counties in terms of barriers to antenatal care. There are some which are systemic, that is more within the health system, and they'd require a bit more of resources to address. And these are some of the, so for example, in some areas, the distance to the closest health facility, if you look at a county like Kitui, 30,000 square kilometers, is very far. They have to walk very, very far, very long distances to get to a primary healthcare facility. So there is that. Secondly, and I've seen this as a question, is also one around, the barriers of still looking at the health system, is the health personnel. Some of the facilities where these mothers would go to, the primary healthcare facilities, which are really at the periphery, they are manned by very lean staff. And in some days where we have been, we do see on average of at least sometimes 40 mothers walking to the antenatal clinic. And because they're so small, it's really a one service point. So given that they have to wait for long and all that, sometimes maybe some feel discouraged. The other things which we now are trying to investigate really is looking at having a significant number of adolescents, is whether there are issues around disclosure, which is stigma. And that's why in the ethnographic study, we are looking at influencers. Because now the issue, trying to understand really disclosure of pregnancy, is something that we pondered and discussed at great length. And that's why having talked to Gretel and others, we thought it was a good decision to probably look at the two-stage approach and more or less consider ethnography as an approach to try and address this issue. So disclosure of pregnancy could be one of the major barriers, because if they never disclose their pregnancy, it will be very hard for them to actually get the services. So that's one of those. So I hope, you know, so we really don't have the answers, and we hope we will get the answers, but I hope that provides some insights in terms of some of the barriers. There are many others, including, if you read most of the papers, it's the iron folic acid supplements, whether they're capsules, tablets, many other things. But for this study, we agreed to focus on that. Thank you.
Thank you, Brian. And I will say that the team also in Uganda has done a baseline and is doing also a focused ethnographic study. What came out from, for example, when women go to health facilities, they were not satisfied with health education. So just to say that those two teams are documenting all the barriers and also bottlenecks and implementation bottlenecks. And this is why they're developing also a bottleneck inventory and hope to be able to move to action and some intervention to address those, and not only having additional research done. So this is all the time that we had for this webinar. I thank very much our panelists and thank you all participants for your insightful questions and the lively discussion. I apologize for the technical problems that we had. It's the first time that we use this platform, so we had to manage a couple of issues. So we hope that the webinar has been informative and thought-provoking. If you have any other questions, you can also contact us. We, as part of the Society for Implementation Science Initiative, we have an address, so info@implementnutrition.com. Also, I'm sure you can also contact 3IE. You can visit the website of the two organizations. Once you leave the webinar, you'll receive a brief survey on the webinar, and we would appreciate if you could take a moment to provide your feedback. You will also receive a follow-up email in a few weeks with a link to today's webinar recording. So again, I thank you so much for joining us this morning. I wish you a good rest of the day. Thank you.